Dear colleagues and friends, it's my pleasure on behalf of Georg Nickenich to introduce you to this symposium on mitral and tricuspid repair and replacement. Mitral and tricuspid regurgitation are not only the most prevalent valvular disorders, but they are important and so far neglected drivers of mortality. And percutaneous treatment of mitral regurgitation as well as tricuspid regurg are one of the most innovative tools we are currently embracing in the field of structural heart disease. Direct annuloplasty, leaflet repair, as well as replacement of mitral and tricuspid valves have become a vivid option of treatment in patients with increased risk of operations. And in the next couple of minutes, Georg Nickenich and myself, we are proud and happy to present to you some of the most visible experts in the fields of percutaneous treatments of AV valves. And without further words, we'd like to initiate this session with the first speaker, who will focus on tricuspid regurgitation and the value of direct annuloplasty using the Cardioband tricuspid system. Roman Pfister, please.
Yeah, dear Chairman, ladies and gentlemen, let me first of all thank Edwards for the invitation and the organization of this symposium. Now, it is about annuloplasty with the Cardioband tricuspid system, and the aim is to tackle the root cause of tricuspid regurgitation. These are my potential conflicts of interest. We usually, in the majority of patients, talking about secondary tricuspid regurgitation. So this means normal leaflet structure, but a dilation of the right atrium, the right ventricle, and in consequence, the tricuspid annulus. And this is even much more pronounced than we know from the left side, from the mitral side, where tethering of leaflets is a major issue of secondary mitral regurgitation. In the tricuspid side, the major mechanism is dilation. So it is quite intuitive to use an annular reduction system to address this problem. And the tricuspid Cardioband more or less mimics surgical ring annuloplasty, but it has different important advantages. So, of course, we do have a device size adjusted to the anatomy of the patient, but also during the implantation process, the flexible band with the individual anchor implantation nicely adapts to the individual morphology of the patient. And also in the end, where we have the contraction process, this is on a real-time basis monitored by echocardiography, and this allows to optimally adjust the perfect contraction stage, balancing efficacy regarding reduction of tricuspid regurgitation, but also safety, so we can adjust for problems of the surrounding anatomy. So having said this, I want to introduce you some recent evidence. We had initially small approval trials in the US and Europe, and we have now first real-world data from two trials, one of which is the Tricuspid trial. It is a European single-arm, multi-center, prospective post-market trial with the aim to further assess safety and efficacy of the Cardioband tricuspid system. And inclusion criteria were symptomatic, severe functional tricuspid regurgitation. Primary endpoint is efficacy, reduction of tricuspid severity from baseline to discharge, but there is plenty of secondary safety and efficacy outcome endpoints. And the follow-up is intended for 5 years, and I can present you now the 30-day follow-up data. 61 patients were enrolled and 59 patients completed this 30-day follow-up. If you look at the baseline characteristic on the upper table, then we get an insight into the clinical root cause of tricuspid regurgitation. These were elderly female patients with preserved ejection fraction, and the majority had pulmonary, usually post-capillary pulmonary hypertension, or atrial fibrillation. So what we treat is a specific subset of the large HFpEF population of patients. When we look at the procedural details, device success, which is more or less technical success according to EMBA criteria, then this was almost 100%. Procedure time regarding skin to skin was about 200 minutes, and regarding implant in and implant out was about 150 minutes, so 2.5 hours, which I think is acceptable. So the efficacy endpoints here, more or less a proof of concept. We observed a significant annular reduction. The septolateral diameter decreased by 20%, and this nicely translated in an improved coaptation of the leaflets with a reduction of TR. You see here the data from qualifying echo, baseline, discharge, and 30-day, and about 60% of the patients and 69% at the 30-day follow-up had a residual moderate or less TR, and 78% and 85% respectively at 30 days had at least an improvement of 1 grade corresponding to the 5 grade classification by Hahn et al. So nice efficacy of this treatment in this patient population. What I think is very interesting here are the early parameters of remodeling, not only of right atrial remodeling and cable remodeling with a decrease in diameters, but also remodeling of the right ventricle with a reduction of diameter of about 4 millimeter, which was highly statistically significant, and suggests that we do not only symptomatic therapy, but there might be an impact on the cause of the disease in mid and long-term outcomes. From the patient perspective, we do have a significant improvement in NYHA class and also a significant improvement in the Kansas City cardiomyopathy questionnaire. 17 points improvement. For your interest, 5 points are regarded as clinically relevant. The second study I want to introduce is an even more real-world experience. Our center, together with 3 large German high-volume centers, gathered their first consecutive patients treated after CE mark approval. And so there were absolutely no clinical exclusion criteria. We did have patients on hemodialysis. We did have patients with pulmonary hypertension, cachexia, and anemia. And the results are pretty confirmatory to the Tricuspid trial. So we had 60 and 67% at 30-day of patients with a residual MR of moderate or less. And also this translated in a significant improvement in symptomatic benefit with NYHA class 1 and 2 patients of 21% increasing to 81%. So in these 4 centers, almost only 1 operator per center did all the procedures, and this allows us an early stage learning curve analysis. And here is the procedural time for the first 5 procedures, 5 to 10 procedures, and then the following 10 procedures. And what you nicely see is a decrease from almost 300 minutes in the first procedures to less than 200 minutes in the procedures 10 and following. And this was achieved without a loss of efficacy or safety. So I think this is a very nice data showing the very early learning curve. And here I want to sum up. I think both these 2 recent trials showed substantial clinical and technical improvements associated with the Cardioband Tricuspid system. The Tricuspid trial showed a very high device success rate. Our last real-world data confirmed these efficacy and safety data on a very morbid patient population, and I think this is particularly important to show for the safety endpoints, which were very good. And now I want to finish and thank you for your attention.
Yes, good afternoon. Now we are live here. Welcome to everybody on behalf of Georg Nickenich. And I guess we have the chance to discuss this first contribution here to this seminar by Roman Pfister. You are all welcome to give your questions into the chat and enable us to make this a very vivid discussion here. But before we answer your potential questions, let's see who's having questions here around the panel.
Maybe I can start with one question. Thank you very much for this wonderful presentation. What would be for you the ideal candidate for a Cardioband procedure, as opposed to other devices being available?
Yeah, I mean, the dilated annulus, of course, is the most impressive thing, and we have to be sure that it is overall not too advanced, and this means in the tricuspid side that in the end you get a tethering as well if you wait much too long. So clearly dilated annulus, but the leaflet should be fine, and the tenting area or tenting angle should be exactly below 30 degrees more or less.
Okay, not too much tenting. Okay, thank you very much.
What about the size of the right ventricle? Is this something which would preclude the use of this band?
Yeah, in an indirect way, of course. So we have a maximum size for the Cardioband, and this in the end means we have a maximum size of the annulus circumference. So we actually, at the moment, use CT to estimate the circumference we want to cover, and this has limitations in the end.
All right. More questions around?
So, please go ahead. No,
go ahead, Georg.
There's the RCA. You mentioned that already. Is this a very frequent exclusion criteria?
I think depends on the experience of the operator. This is what we learned in our early cases. Of course, there are cases where we have proximity to the RCA, which covers, I think, 50% or more of the whole Cardioband, and this will be a problem in the end. But if you have, I think, 3 or 4 segments in proximity to the RCA, it shouldn't be a problem for an experienced operator. You can skip individual segments, you can cross the RCA, and usually in the end, this will not negatively impact the result.
How often do you have to skip an anchor due to proximity, for example, of a vessel here?
Yeah, I think overall we are very liberal regarding denials of patients for RCA proximity. So I think we have a pre-selected high-risk clientele in our department, but skipping segments is not a problem overall regarding efficacy of the system. If you skip 1 or 2 segments, which are not besides each other, and I think every 5th or 6th procedure we do have to skip a segment.
So how do you do this? You just screwing it in the air, or because you can't skip the anchor?
Yeah, I mean, first of all, you try, and if you did have several attempts and you couldn't manage, or you don't have sufficient tissue to anchor in, then you just skip it without anchoring into the segment. So you relieve band and go to the next segment.
Okay.
One last question by Jörg Hausleiter.
Yes, a very nice presentation. I have a very brief question about the imaging, because imaging is sometimes with tricuspid valve very, very complicated. Can you comment on the patient selection and the image quality you need to get a good tricuspid band result?
Yeah, in the beginning this was an issue, but we gained experience here as well, and combining transesophageal and transgastric views usually make imaging not a big problem. So really rare cases where we deny because of low imaging quality.
Thank you.
Right. Thanks so much, Roman Pfister. I guess we have to move on now. And we move from annuloplasty to leaflet therapy, and are awaiting the talk from Peter Lüdike from Essen.
Well, first of all, I want to thank you very much for the invitation and the opportunity to be part of the EuroPCR 2021. Well, these are my disclosures, and these are the points I want to cover within the next minutes. But before we start to talk about the technical innovations of the PASCAL device, I just want to remind ourselves why we actually have to talk about innovations in the field of edge-to-edge repair, despite we have more than 10 years of experience. And what we learned from this 10 years of experience, the first learning is that leaving the patient with an acceptable result is not a perfect result. And we learned that we definitely should reach out for a MR reduction of a level of 0 or at least 1+. What we also learned from these 10 years of experience is that leaving a patient with a too small residual valve opening area will hardly translate into a benefit for our patient. And the same is with the mean pressure gradient that often comes along with a too small residual valve opening area. And I think 5 millimeter mercury as a threshold we should definitely respect, especially in patients with atrial fibrillation. And finally, technical success and procedure safety remains the cornerstone of successful edge-to-edge repair. And this is basically a learning from MITRA FR and especially when we compare the results of MITRA FR to the co-opt data. Well, the PASCAL technology entered the European market 2019 with a claim to address all these landmarks and to make edge-to-edge repair more effective and safer. And 4 novel aspects were added to the well-known principle of edge-to-edge repair, and I will comment on them later on. And last year, a second size of the PASCAL device, the PASCAL Ace, became available. And this second device perfectly complements the existing PASCAL 10 platform since it has a narrow profile, flat shoulders, a flatter spacer, and makes it an ideal candidate for anatomies and circumstances where the PASCAL 10 might not be a suitable candidate. Well, the central spacer was designed to reduce the stress on the leaflets and to fill the regurgitant orifice between the leaflets. But by doing this, the spacer addresses more or less all of the aforementioned key aspects of a successful edge-to-edge repair because it maintains an even increased diastolic valve opening area. It avoids thus a development of high gradients and finally effectively closes the insufficiency gap. The second mechanism or the second feature, the independent clasping mechanism, is not only a feature for overcoming difficult anatomical circumstances, like we see this in this echo movie from a patient we treated with a very complex tricuspid disease and a congenital heart disease. But more than this, we learned that optimizing the leaflet capture through independent grasping improves our results. And this is, first of all, a mechanism that increases the efficacy of reducing residual MR with the PASCAL device. And since the retention features of the PASCAL are aligned parallel to the collagen fibers of the leaflet, this maneuver can be done again and again without the risk of laceration of the leaflet, even in very old patients. Another important safety feature is the capability to elongate the whole device, thus creating flat, nearly a straight profile, what helps you to get out of entanglement with chordia, as you can see in this fluoro loop of a patient we treated with a very medial pathology, and we tangled up time and again. And it was just easy to straighten the PASCAL, pull it back and start again, and without the risk of injuring the tissue. And this aspect of safe and atraumatic maneuvering that comes along with a smooth nitinol design of the device that applies passive constant closing forces using some kind of a memory of shape principle to avoid damage of the tissue. And this is an important learning, avoiding deformation of anatomical structures. And the latter aspect might be a reason why the MR reduction after release of the PASCAL device from the delivery system maintains at least stable or empirically even improves. And since anatomical structures cannot be distorted with this smooth device, and this was a key learning during my early phase of experience with the PASCAL technology. So we can see that the PASCAL actually addresses all the aforementioned aspects that determine prognosis and benefit after edge-to-edge repair. And the latest innovation, I just want to comment on this during this little movie, is a new stabilizer system, this the so-called SRS system. This uses a rail-based mechanism to stabilize the flexible system on the one hand, but maintains the flexibility of the PASCAL device on the other hand. And especially the latter aspect, the flexibility of the system, is a real game changer from my point of view. When you learn to understand, especially when you switch from one technology to another, that this flexible steering mechanism and device properties saves you from placing it where it should simply not be. And that is a great tool to obtain convincing and long-term, short and long-term results, and especially to have a safe procedure. Well, to date, we have just limited data from prospective clinical trials. And when we take a look into the 2-year follow-up of the CLASP study, what was the first prospective single-arm study, there are 48 patients available for 2-year follow-up. And we can see that the long-term survival, as well as heart failure endpoints, and are at least comparable to other clinical trials in the field, and that the sustained reduction of MR over time is accompanied by a favorable remodeling, left ventricular remodeling, and sustained improvement in New York Heart Failure Association functional class over the time. Well, these are the only prospective data to date, and the upcoming data from the CLASP to D to F trial and the MyCLASP registry will give a very more comprehensive insight into this new technology. When we look on what is happening in the real world and take a look in this industrial data set from Edwards Lifesciences that consists of report of all the proctors in the field who document the key characteristic of procedures, anatomical circumstances and outcomes, acute outcomes, we see that there are more than 2,000 data sets are available at the moment. When I first commented on this data set, there were just 1,000 patients available. In the meantime, it's more than 2,000, so it's very big data. And what is obvious on first sight is that even in the very early phase of this device in the field, the majority of cases ends up with an acute MR reduction of 0 or 1 plus, a perfect result. In 3/4 of the cases, and nearly 100% to a level of at least 2 plus. And this stratification to different etiologies and endpoints shows that it takes just a relatively short learning curve from approximately 25 cases to decrease procedure time and to improve your results so that you can end up at your center with an MR reduction to 0 or 1 plus in over 80% of the cases. And while this data set is very suggestive, obviously, we definitely see a comparable trend in our own institution where we prospectively evaluate every PASCAL procedure and see a reduction to a 0 or 1 plus result in more than 80% of the cases. And it's important to mention that this is a non-selected data set. So this is an all-comers cohort, and we have a 30-day mortality of 0 at the moment. So a very impressive safety profile. The only available comparison in the literature of PASCAL to the mitral clip technology comes from the colleagues in Bad Oeynhausen in Germany. This is a recently published retrospective comparison of PASCAL versus mitral clip in severe primary MR in patients with prohibitive risk for surgery. And these data suggest that PASCAL might be even more effective in this specific form of DMR. But as I mentioned at the beginning, we still need prospective data from randomized trials to draw a final conclusion, especially when talking about non-inferiority, inferiority, superiority, when comparing the existing systems. But what we can definitely, what can be stated definitely at the moment is that after 2 years of experience, the PASCAL technology is a very safe and effective therapy that addresses more or less all the shortcomings that we've learned in more than 10 years of edge-to-edge repair in the past. A very exciting journey, and maybe we have a little time left for some questions. And thank you once more for the invitation to PCR 2021. Thank you very much.
Yeah, thank you very much for this nice presentation, which is now open for a discussion. Until some questions pop up from the chat, maybe some questions from the panel. Maybe I start with one. So comparing the two leaflet devices, just imagine you have both devices in the shelf and you don't have any restrictions caused by the companies. Which one would you use for which patient, or or is there no selection criteria for this?
You mean the differentiation between PASCAL and PASCAL Ace, or you mean the differentiation between PASCAL and mitral clip technology?
Both.
Both. I think this is what I mentioned quite early in the talk. I think it's very, very early to make some kind of an algorithm. What we try to establish at our institution is that we prospectively evaluate all comers cohort by using just PASCAL and PASCAL Ace, just to learn if there pop up some anatomical limitations that urge us to use a different technique. And when we look on the other side, the other technology available, there's so increasing options for edge-to-edge repair in the field now after the CE launch of the PASCAL 2 years ago, that I think it will take some time before we definitely know how to choose which device for which anatomy or which patient. I think it's very early, and what I can say from our experience now is that it's we see until now no anatomical limitations that urges us to use a different technology.
How about the gradient, baseline gradient or orifice area?
Recent analysis that we've done and that shows us that there is nearly no difference in the follow-up and the meantime follow-up that we analyzed now. And when we compare the two technologies from the past and what we selected prospectively, this was 3.4 to 3.6. So there was a non-significant difference. This is something I expected at the very beginning because of the size of the device, but basically it looks like that this is not a problem.
Now the question was selection of the device. If the patient enters, sorry for interrupting you, if the patient enters the cath lab or the hybrid room with a gradient of, let's say, already 2, 3, or 4, which device would you choose, or doesn't it play a role for you?
Now we don't make this decision dependent on the
PASCAL Classic and Ace. You wouldn't distinguish.
No, especially on the mitral side, we still go primarily with a PASCAL 10 device, and the classical cutoff is a DP mean of 5 millimeter mercury, and below this we just go for PASCAL 10.
Okay, thank you. Do we have time for another question, Stefan?
Well, I guess we need to move on.
Okay. So then we need to go move on, if Stefan says so. And the next one is Edwards Portfolio in Action, and this is done by Dabit Arzamendi. We are looking forward for your presentation, please.
Hi, this is Dr. Arzamendi from São Paulo Hospital, Barcelona. I'm presenting 2 cases of the mitral valve repair with the edge-to-edge technique with the PASCAL system. We have selected these 2 cases because we think that it emphasizes the special feature of the device that it makes probably unique in this setting. So the first case, it was a 60-year-old male with ischemic cardiomyopathy with moderate LV dysfunction and with a severe functional MR. He got admitted to emergency room several times. So for this reason, he was studied for mitral valve repair. This is his TOE. As you can see, he had a broad MR. You can see it in the intercommissural view. So for this reason, we thought that we might need more than one device. But on the other hand, if you check the LVOT, the quality of the leaflets is not really good. Despite it was described as a functional MR, there is some frayed leaflet in the posterior mainly. And for this reason, we were concerned that we might have some problems with the leaflet tearing. And for this reason, we saw that the PASCAL device was the device to choose because, as you know, the Pfister reduces the stress of the leaflets, and at the same time, we are able to feel more regurgitant orifice area. So we get the both things at the same time. So this is the case. The thing is that we got a really good transeptal, and for this reason, we were really well aligned with the valve. And in the first attempt of grasping, we got a lot of amount of tissue, anterior and posterior leaflets. Normally, when we don't have to see it clear, we optimize the leaflet grasping at this moment. But since we saw a lot of tissue inside, we thought it was already a good clasping. We closed completely the device, and we had a really good result with a significant reduction of the mitral regurgitation with a mild MR toward the lateral, and the LA pressure went down from 48 to 12. The patient did really well, and he was discharged 24 hours later, and he didn't get any other admission in the emergency room during the 6 months of follow-up. And this is the TOE at 6 months, and you can see that there was still a mild MR, almost a really stable result comparing what we got at the beginning. The second case is a 60-year-old female with degenerative MR that it was due to a P3 prolapse. She had also some issues with the bleeding, and she was refused for surgery because the geriatricians considered that she was too frail. So she was studied to transcatheter mitral valve repair. And as you can see, the case wasn't really promising because she had a large P3 prolapse. It measured like 13 millimeters. And we were concerned that it had a really weird angle. And to have an axiality with the leaflets, we thought that we might need to go down close to the chordae, and this was one of our main concerns. So for this reason, we thought that the PASCAL Ace device was probably the device to choose. For one side, because if we got trapped or entangled down the mitral valve apparatus, we will be able to elongate it, and it's a really safe maneuver to take it out. And on the other hand, compared to the PASCAL regular device, the PASCAL Ace allows us to grasp more tissue, 1 millimeter each side, and we thought that for this large prolapse, it would be a really good device. So this is the case. We did several attempts of grasping, and indeed we got entangled a couple of times in the chordae, but it was really safe to take it out just with elongation. At the end, we accepted this position that it was like some sort of 11-5, and with that, we were able to get all the prolapse inside. Despite that, there was a moderate MR towards the lateral, and since the mitral mean gradient was of 2, we decided that it was worth it to put a second device to get it completely fixed. And this is what we did. The truth is that the second device was really easy to position because after all these tries that we did with the first one, the second one was just to put it side by side. And as you see, we got just a trace of mitral regurgitation, and the LA pressure, the D-way went down from 52 to 14. So the patient was discharged 48 hours later, and during the same procedure, she had the appendage crushed also. And this is what you can see at 6 months follow-up TOE. The result, it looks even better, and the residual MR is really, really traced, and the appendage is perfectly closed. She did really well, and she didn't got any other admission for heart failure. So these are the data of our first experience with the PASCAL device. As you can see, our average time of procedure is less than 1 hour. On those patients that has been treated with a regular PASCAL, we've been able to get a mild or trace MR in almost 83% of the cases, and none of the patients got a severe MR as a result. And if we go to the cases that we did with PASCAL Ace, that most of them there are prolapses, we got mild or trace MR, residual MR in almost 100% of the cases. So really promising results. And as you can see in the follow-up TOEs, they seem pretty stable. So in conclusion, the H2H mitral valve repair with the PASCAL platform offers benefits in several scenarios. We wanted to underline 2 specific ones in functional MR, and when you don't have a really good quality of leaflets, I think PASCAL is a really, really interesting device. And in the relative MR, it's really a good device to place close to the commissures, because the safety maneuver that we have with the elongation is really, really useful. And especially PASCAL Ace is really useful in prolapses to get the full prolapsing tissue inside the device and get the perfect result. Thank you.
Great cases, David. Thanks so much for presenting them to us. Any questions here from the panel or the audience? My question would be, do you see independent grasping more in functional or more in degenerative MR in your experience, or do you need it for both entities?
And in our case, we are not really, we don't use it often, the individual grasping. We use it just to do the optimization once you get some amount of tissue in both sides. So I'm not a huge fan of doing one grasping of one leaflet and going to the other if it's not absolutely necessary. This maneuver, maybe we have used it more often in tricuspid, but normally we try to get some amount of tissue symmetrically, and after that we try to do the optimization. And at this moment, we use this maneuver of individual up and down of the clasp, but we don't try to use it. And if I have to choose, I will use it more often probably in the functional, if the tissue, it's a matter of the quality of the tissue, right? Indeed, that was the question I wanted to ask before. If you feel, so if you're gonna use this individual grasping the same way with the G4, because sometimes I'm concerned maybe that the type of patient that we are treating, they are old people, and the quality is not so good. And my feeling is that maybe the tension that you are getting sometimes in the leaflet, it's too high, and we are pretty concerned with the leaflet tearing. So that's why we feel really comfortable with PASCAL, because it's something that every time when we do this optimization, we never have any issue. I think it's not so, it doesn't push so hard into the leaflets.
And is in degenerative MR using the ACE the default mechanism, the default choice you tend to, or is this, do you make it dependent on the morphology in degenerative MR? Which one?
That's right. It's more morphology. I think it's in this case, the cases that we've used the ACE, all of them, they have been prolapses, and the aim is to get to grab all the tissue inside. Our feeling is that if you miss some amount of prolapse, and when you follow them later, the MR comes back. So that's why we think it's really important to get all the tissue inside, and for that, this makes a little difference. You can get more tissue inside.
I guess we need to move on for the sake of time, if this is okay for everybody, and go on and basically back to the tricuspid area, and we'll hear something from the PASCAL Ace system for treatment of tricuspid regurgitation, presented by Philip Raake.
Dear ladies and gentlemen, thank you very much for giving me the opportunity to present our experience with treating tricuspid regurgitation with an interventional approach with the PASCAL Ace device. So tricuspid regurgitation is a disease which we are able to treat now with an interventional procedures. And regarding the tricuspid valve, we have to have in mind that the valve is much more complex than the mitral valve is, where we have experience with treating mitral regurgitation for some years. And so treating tricuspid regurgitation is new. And the things which you have to have in mind when you treat tricuspid regurgitation is that the leaflets are thinner and might be more variable than on the mitral side. The annulus might be much larger. You might have wider gaps between the leaflets, and the chordal network is much denser, which makes it more difficult to load the leaflets on your device. So today I want to introduce you to the PASCAL Ace implant. You might know the PASCAL implant, which was CE marked a few years ago. The PASCAL Ace implant was CE marked last year, and it's also available for the tricuspid regurgitation as the PASCAL device is. The PASCAL Ace implant has a smaller design. The pedals are a little bit more narrow, and the clasp are slightly longer. And you know that the device has the ability for independent leaflet grasping. You capture one leaflet first, and then you swing over to the other leaflet and capture the second leaflet in a second attempt. And this is important for treating tricuspid regurgitation. So the narrow design that might be a little bit more advantageous regarding tricuspid regurgitation, as you know that there is a very dense chordal network. So we at our center here are primarily using the PASCAL Ace implant for treating tricuspid regurgitation. There's some experience using the PASCAL device for tricuspid regurgitation. This is a compassionate use, results of 12 months. You can see that the tricuspid regurgitation rate was reduced at 30 days and 12 months. And the reduction of tricuspid regurgitation was very durable. And this is the survival of the patients and survival in heart failure hospitalization. So overall, this was a durable result in this compassionate use of PASCAL tricuspid regurgitation. Second, I want to point your attention to the CLASP TR trial. This is the 6 months results. Here, 63 patients were enrolled in a prospective study. Almost 70% of these patients have massive or torrential tricuspid regurgitation. And in this trial, the tricuspid regurgitation severity was reduced at 30 days, and the results were very durable over 6 months. And this was a significant reduction of tricuspid regurgitation. which was also seen by the PISA and the vena contracta. So very durable results with using the PASCAL device. So the class 2 trial, that's actually a prospective randomized trial, which is on the way, comparing optimal medical treatment and optimal medical treatment in combination with the PASCAL treatment of tricuspid regurgitation. So this is our experience regarding treating the tricuspid regurgitation with the PASCAL Ace device. So we used almost exclusively the PASCAL Ace device for treating tricuspid regurgitation. So this is the TR grade and EuroPCR class on the right side. You can see this is the first column is before implantation, and this is up to 1 month after implantation. You can see that the TR grade was reduced significantly in these patients, and the patients improved in EuroPCR class. Regarding echocardiography, we saw that the right atrial and right volume and the right ventricular and diastolic diameter both were reduced significantly in our patients after treatment of tricuspid regurgitation. Actually, this was a compassionate case, so we treated first the functional mitral regurgitation in this case with a PASCAL device, and in the same procedure, we treated the tricuspid regurgitation with a PASCAL Ace device. So first, I would like to show you the treatment of the functional mitral regurgitation. This was actually a moderate to severe functional MR Carpentier 1, which was treated first. This is actually the era here of this case was a moderate to severe functional mitral regurgitation. On the left side, you can see the capture of the mitral leaflet. This is the anterior, this is the posterior leaflet. And you can see that we did a leaflet optimization here. So we reopened on the posterior side, the clasp, and we did leaflet optimization here. You see that the leaflet that is closed first, the device on both sides, so the anterior and the posterior clasp, and we reopened, we moved to the posterior leaflet, and we reclosed the device only on the posterior side to do a leaflet optimization here. We were satisfied with the result on the mitral side, and the device was released, and this is the final result with a trace to first degree MR, in this case on the mitral side. And then we moved over to the tricuspid. Here you can see the massive tricuspid regurgitation. And we used a PASCAL Ace device for this case. You see that we did a first attempt here in the anterior septal leaflet. You can see the movement of the device, which is, and in this case, we did also a tarsal maneuver. We captured the anterior leaflet first. We swung over to the septal leaflet and captured the septal leaflet. And we had this first attempt where you can see that the result was not optimal. So we decided to go for a second attempt, and we went a little bit more central in the tricuspid valve. You can see that the device is more centered here. This is the anterior leaflet, which was captured a little bit more in the center of the valve. And the clocking was changed a little bit clockwise. And we were very satisfied with this result, as we had a trace TR as final result for this patient. So this was actually a very good result. And this was done within one case. And it took us roughly 45 minutes to 1 hour to treat mitral regurgitation and the tricuspid regurgitation in this case. And this is the fluoroscopic image. You can see the PASCAL device on the mitral side and the PASCAL Ace device on the tricuspid side. So finally, I would like to point you to our algorithm, which we're using here in Heidelberg, which we use for treating symptomatic severe to torrential tricuspid regurgitation. So either the patient is asymptomatic, we would go for a monitor the symptoms and see if we can improve the atrial fibrillation treatment. If the patient is symptomatic, we want to understand if it's a primary or secondary tricuspid regurgitation. If the primary device lead is responsible for tricuspid regurgitation, we have to understand if we can improve the lead of the device. If this is not the case and the patient has an elevated surgical risk, we would go for interventional leaflet repair. Otherwise, we would think about surgery, but this primarily in combination with left-sided heart surgery. If the patient is symptomatic in secondary tricuspid regurgitation, which we see in many of our heart failure patients, we would try to optimize the treatment of atrial fibrillation. We would try to fluid balance the patient, to do a negative fluid balance and to withdraw fluids. And if the patient is further symptomatic and the TR is still severe, we would go for an interventional leaflet repair. So I'm at the end of my talk. I'm very happy to present our first experience on treating tricuspid regurgitation with the PASCAL Ace device, and I'm very happy to take your questions. Thank you very much for your attention.
Thank you very much for this two very nice presentations. And they are now open for discussion and questions. Maybe I can start with one to Philip Raake. You showed this nice scheme how you proceed with the patients in Heidelberg, which is I think more or less also generalizable to all the other hospitals. And you have this one box pre-treatment of the patients. Maybe you could a bit allude how you would pre-treat and prepare a patient once you have selected him for a procedure. Do you bring this patient in early? How about diuresis? How about hydration state and stuff like this? Maybe you could explain that a bit to us.
Thank you, Professor Nickenig, for this very important question. So we usually want the patient in a fluid optimized state. So either we do that in an outpatient setting. So we have a heart failure outpatient clinics here where we increase the oral diuretics, and we schedule the patient for a revisit like 1 or 2 weeks later and to see if the tricuspid regurgitation changes. And we also look at the peripheral edema and the vena cava width, and if we see that the patient is in a recompensated state and still has high-grade TR, then we would go for the procedure and schedule the procedure. If we have the impression that the patient is too sick for an outpatient setting, then we will just take him to one of our wards and have him optimized in an inpatient setting. And if we see that the patient recovers and the tricuspid regurgitation is reduced by oral diuretics, we will not go for the procedure. So we really try to stick with the procedure for the patients who really need it and who need it in a recompensated state.
Okay, may I add one more question for you? And once you have done the procedure, you showed this nice results. How do you proceed with the treatment after a successful device implantation? Do you stick to the diuretics? How do you do this? I mean, there are no guidelines, no data out there.
Yeah, that's a good question. So we usually the patient after the procedure is like in the hospital for 3 to 4 nights, and then we'll discharge him. And during that time, we will try to optimize the diuretic regimen, which is a short time frame. So usually we schedule the patient for a revisit in our outpatient clinic 1 month after the procedure. So we will try to optimize the diuretic treatment during these 3-4 days, or sometimes 6 days after the procedure in the hospital, as long as we need. And we want to discharge him in a stable status. And then we reschedule the patient one month, usually after the procedure, and then after 6 months, and then after 12 months. And this is how we see these patients in our outpatient setting.
And we are now looking forward to seeing one of the highlights of this symposium, a live in the box case presented by and performed by Philip Lurz. So let's go, I guess.
Hello and welcome to Heart Center Leipzig for PASCAL Tricuspid Valve Implant. I have with me my dear friend and colleague, Thilo Noah, cardiac surgeon. We will also have with us Nobi Kitamura, our fellow from Japan. We will be guided through the procedure by Professor Ender on the echo. And we have with us Carsten Leng, Daniel Laval, Marie and Annette and Simon. They're all supporting us. And without further ado, I'm going to ask Nobi to present the patient to us.
Good day, everyone. We treat our patient, an 81-year-old female. The BMI is 27 kilogram per square meter. She was recently hospitalized to our University Hospital due to decompensation of heart failure with preserved ejection fraction. She has permanent atrial fibrillation, breast cancer after surgical resection and radiation therapy, and type 2 diabetes. Despite guideline-oriented medical treatment, she presents with further exertional dyspnea of NYHA class 3. Therefore, she was referred to our valve team for further cardiac treatment. Cardiac catheterization demonstrated post-capillary pulmonary hypertension with pre-capillary component, and the mean pressure is 31 millimeter Hg. The coronary angiography showed only intermediate stenosis of mid-left coronary artery without indication to coronary intervention. The both right and left ventricular systolic functions were preserved. As you see here, severe functional tricuspid regurgitation is demonstrated by these echocardiographic images, which were obtained 3 weeks ago. A 6-minute walk distance is 261 meters, with 2 times pause during the test due to dyspnea. And the NT-proBNP is 1,100 nanogram per liter, and the eGFR remains almost within normal range for high age. The Euroscore 2 is 2.9%, and the STS score for isolated mitral repair is over 10% mortality. The severe functional tricuspid regurgitation is considered as the cause of her symptoms. However, the operative risk of tricuspid valve surgery is prohibitively high due to her age, pulmonary hypertension, and after radiation therapy. Therefore, we decided to perform transcatheter tricuspid valve repair using the PASCAL Ace system for this severe tricuspid regurgitation.
Thank you, Nobi. So to some extent, this is what we quite often refer to as a AFib TR or atrial tricuspid regurgitation. We're going to now ask Jörg Ender to demonstrate us the live echo views and then to decide on the strategy.
According to the TTE, you see a very large right atrium and not so much enlarged right ventricle. The diameters on the tricuspid annulus is 4.4. You see in color Doppler a huge regurgitation jet all over the coaptation line with a biplane vena contracta of 1.6 centimeters and an effective regurgitation orifice area measured by PISA from 0.7, which is a massive tricuspid regurgitation. You see a holosystolic reversal in the liver veins. And here's the transgastric short axis view where you can very nicely see the anatomy of the tricuspid valve. You see the septal leaflet here, the anterior leaflet and the posterior leaflet. And on the right side, the according color Doppler flow.
Okay, I would like to talk a bit about the underlying pathology. What we can see very nicely in the ultrasound pictures is that we have an 4-leaflet configuration with an anterior, mural, and a posterior, and also a septal leaflet. The core lesion is located centrally and also between the anterior and posterior leaflet. And the strategy for that case is that we place the first device between the anterior and septal leaflets more on the central side of the anterior leaflet as much as possible, and then we will assess the residual mitral tricuspid regurgitation, and then we will decide to implant a second device centrally between the mural and the septal leaflet.
Thank you. And we're going to use a PASCAL Ace device. These days, this is our default device when treating tricuspid regurg and choosing a PASCAL device. This is a slightly smaller device with a width of 6 millimeter, which allows us to implant 2 devices, even on small landing zones, and also is very easy to image on echo, which you will see in a second. So what we've done so far, we punctured the femoral vein in the right groin. We advanced the sheath into the right atrium. We're now going to advance the PASCAL Ace device through our guide, which is introduced with that loader. We advance the PASCAL device. We will assess both on echo and fluoroscopy. You can see now on echo and fluoroscopy the device leaving the sheath. And this is then the time to close the device. Okay, so Thilo is turning the knob at the end of the implant catheter and thereby closing the device. The next step is then to steer down to the tricuspid valve. So before we do that, we're going to stabilize the whole system. We have that rail with 2 stabilizers to stabilize this 3-component system: the guide, the steerable catheter, and the implant catheter. What we're going to do now is to steer down to the tricuspid valve by advancing the device out of the sheath and at the same time introducing some flex on the steerable, and thereby we're going to dive down towards the tricuspid valve. What we're going to do next is to connect pressures. So here we have the opportunity for simultaneous pressure tracing by connecting pressure line to the steerable catheter. So the next step is to make sure that on an X-plane view, having on the left bicommissural view and on the right the corresponding grasping view, to make sure that we align the system in a truly orthogonal trajectory towards the tricuspid valve before we cross the tricuspid valve. This will facilitate the procedure later on a great deal. So what you can see now, if we advance the device towards the tricuspid valve, we can assure that it runs very straight and in a 90-degree fashion towards the tricuspid valve annulus. On the left, we probably could still be a little bit more 90 degrees, which we achieved now. Okay, the next step then is to open the device. So we have the device now open. The trajectory is quite good. An orthogonal approach towards the tricuspid valve. Now we bring down the clasps individually to enable us later on to do independent grasping. You can nicely see here now that was the anterior, the anterior clasp. And now Thilo will bring down the septal clasp as shown now. Next step is then to close the device. Then we are ready to cross the valve. But before we do so, we like to have a breath hold to have the anatomy and everything as stable as possible. So can we have a breath hold, please?
Yes, breath hold started.
Okay, so now we cross the valve and then we go to a transgastric view, please. So we open the device only after confirming that we are in the right spot. You can see the device being too centrally. I move everything in now and thereby we move more anteroceptally, as you can see here now. I did 2 things. I moved in the whole system, but also released some flex on the steerable catheter. Okay, so here we are on the right spot. We're going to open the device now. Very good images. Okay, so we check on fluoroscopy that the device is open. We won't see it on echo now because we are with the imaging plane. We are just at the level of the coaptation of the leaflets and the device is below. We're going to move into the imaging plane now by pulling back the device. And in a second, you'll be able to appreciate the orientation of the device. Okay, there you go. You can see that we are sort of in a 2 to 8 o'clock fashion, which is fine because it corresponds to 90 degrees to the line of coaptation between antro and septal leaflet. I'm going to move now into the anterior leaflet a little bit. Now you can see that the motion of the anterior leaflet is limited. That indicates that we have leaflet tissue on now. So we bring down the clasp now. When you have as good images as we have now on a transgastric view, I like to perform these procedures guided by transgastric images. Okay. So we have the anterior leaflet on. We now move over to the septal slowly with the steerable catheter turning clockwise and trying to get the septal on. We can also use the guide and turn that a little bit. What we could also do is we could let's go to a mid-esophageal view to assess how much septal leaflet we have on, please. Okay, you can see that we are close to the septal. Some is on, but I think we can do better. And move up and further into the septal leaflet. Not sure whether that's sufficient. Let's close the device a little bit to have a bit of a V shape. Okay. Okay, I think it's on. Let's bring down the clasp. Septal is down, and now we close the device. What we'd like to see now is tension building up on the leaflets while closing the device. Okay, device is closed. I think there's some tension on. Let's go back to breathing.
Start ventilation, please.
On the left, you can now see the color. You see that we still have some TR centrally, which is fine because we are prepared to place their second one. What we would like not to see anymore is TR antroseptally. So between the device and the aorta on the left, I think that's fine. And then let's go to transgastric view, please. Okay, so on the transgastric view, you can now see that we place the device in the position we aim for, antroseptally. You see the restriction in motion of the anterior and septal leaflet, indicating that they're both nicely in with a good chunk of leaflet tissue. And what's most important, we reduce the anatomy. Everything seems to be a little bit smaller. And the central gap, that's the most important bit, is smaller now. So in some respect, this first placement facilitates then the placement of the second PASCAL Ace, which will go centrally. So in the imaging you're looking at now on top of the first one. Can we have some color, please? Okay, so you can see that obviously there's still some color centrally, but that became smaller. So I think we did what we wanted to with the first one. We're going to release this one and then we place the second one on the top of the first one.
Now we move on with the preparation for the release of the PASCAL device. Therefore, we have to cut these two wide sutures. These sutures are connected with the clasp of the PASCAL device, and we can cut these sutures on the lateral side each. Then we pull out both sutures. So then we pull out the safety pin, and then we can turn this blue knob counterclockwise under fluoroscopic control. And in the fluoroscopy, you can see a black line directly in the PASCAL device, and this black line is connected with the blue knob. And doing turning counterclockwise, I pull back a little bit, and you can see that this black line moves to the implant catheter. And these will lead to the release of the PASCAL device.
Okay, it's released. It's still there. It's moving a bit throughout the cardiac cycle, but it seems to be stable with both leaflets nicely in. And this is also confirmed on echo. Okay, good. I think we prepared everything for the second device. Okay, we are ready with the second device, which we will advance now through the guide. We de-aired it and flushed already. So fundamentally, the second implant, the steps, they're the same as for the first one. Some aspects are a little bit easier because we now have a very nice landing zone on fluoroscopy with the first device being in there to guide the second implant. But obviously we have to make sure that we won't get entrapped or entangled with the first one, with the first device. But the individual steps, they are the same as for the first one. So again, we come out of the sheath with the device, we close the device, thereby the device will foreshorten, and then we steer down within the right atrium towards the tricuspid valve by introducing flex on the steerable catheter. We then again make sure to have a nice orthogonal trajectory towards the tricuspid valve. Which I try to make sure now, as you can see on the right, by turning the guide and the steerable in opposite directions. If we now advance and pull back the system, the implant, you can see that it runs straight towards the tricuspid valve, which is what we would like to see. What we're going to do now is we prepare everything, we reopen the device, we make sure which clasp is which one to be prepared for independent grasping, and then we will cross the valve during a breath hold, and then doing everything, the whole implant, probably on a transgastric view, during one breath hold. Okay, so again, focus on the right. We will bring down the clasp now. First clasp. This one is septal. And the other one has to be anterior. And then it's on Tilo to remember which one is which. Okay, we close the device. Breath hold, please. Okay. So on fluoro, I would like to be quite close to the first one. What I'm going to do is I move away a little bit from the first device, cross the valve, and then later on, once we cross the valve, move further towards the first one. Okay, we are underneath, and now we go to a transgastric view, please. Again, we make sure that we're in the right spot. Then and only then we open the device. This is only to make sure that in case you ended up in the commissure, you don't want the device being fully open because then you might get trapped somewhere. But even if so, remember with this device, this device can be fully elongated, which helps you to get out of trouble if needed. Now again, pulling up the device into the plane. Okay, I think the clocking is fine. Let's double check on mid-esophageal, please. Okay, septal is very good. Anterior is difficult to see because we have shattering of the first one. But I think I'm above. Okay, so we're going in a little bit. Okay. So we are in the perfect spot. We open the device. Okay, we ask echo to stay exactly. We ask Ender to stay with the plane where he is, because this is perfect. We bring up the device. We should see it in a second, the orientation. I think we could open the device a little bit more. Okay, can we see septal a bit better? Okay, now I think we're in the right spot. Okay, can we move echo probe a little bit to see septal better, please? Okay, septal is on. Okay, anterior is on. Okay, let's bring down the clasps. I think we can bring down them simultaneously. All right. And now we close the device. We're staying on transgastric. And ideally, we can now appreciate the two leaflets coming together, the device closing, and the anatomy being reduced. Okay. This it is. Breathing on, please. Okay, so now it's time to assess everything properly, look at for leaflet insertion, but also the degree of residual TR. Jörg Ender, could you please help us?
Yes. So you see in the transgastric view, the color Doppler, which shows here a very central small regurgitation jet. Metaesophageal, it was really hard to measure anything because you see that the regurgitation jet doesn't go very deep in the right atrium. So with a little bit trick, we measured a ROR of 0.2, which would be a mild regurgitation. We looked then for leaflet insertion, where you nicely can see the anterior and the septal leaflet running into that clip. Here again in another projection. So we are very happy with the leaflet insertion. And we looked for the liver vein backflow. That is, don't worry, that is the pre-op venous backflow, where you see a holosystolic backflow in the liver veins. And that is actually right now. So you see no backflow in the liver veins in systole. And that is a sign which shows that the reduction of the tricuspid regurgitation was really very effective in case that you cannot measure good TR regurgitation with other methods. So I give back to.
Yeah, we totally agree. I mean, it's non-trivial to assess TR once you place two devices in there. The measured ERA indicates a residual TR of 1, which would indicate a reduction from 4 to 1, which is great, we believe. But as said, not that easy to assess. Hepatic vein flow, in contrast to that, easily accessible. And when you see complete abolishment of flow reversal, we are happy. I mean, this is what we would like to see in these procedures. Okay, then we release, and then we do our final assessment. The connector between the implant catheter and the device is coming back, and now it is free. It jumped a little bit because there was still some tension on it. But you can see the two devices nicely being in parallel, moving throughout the cardiac cycle, but not rocking. So I think this is good. And on echo, we have the same degree of TR, certainly not more than we had before. Maybe let's go to a final transgastric. Well, that looks good. And here as well. Good. I think we closed off that central coaptation gap, which is fine. Okay, but one last assessment of hepatic venous flow.
And you see no systolic backflow.
Okay, so that's good. All good. So I think in conclusion, we treated a typical patient, an elderly lady with HFpEF, with what we refer to AFib or atrial functional tricuspid regurgitation. She was clearly symptomatic due to her actually massive tricuspid regurgitation. Obviously, prohibitive surgical risk. We implanted two devices, the PASCAL Ace device, which has a passive closing mechanism, should be quite gentle to these suspectively fragile leaflets using the Ace device, which is a little bit smaller device, which allows to maneuver within and across cords. We implanted the first one intraceptally, reduced the anatomy already, which then facilitated the placement of the second PASCAL Ace right in the center of the valve where we had the largest coaptation gap, and thereby we reduced the TR from grade 4 to grade 1, and that should translate into clinical benefits as normally seen in these patients. I would like to thank the team for the great support and you for your attention. Thank you.
Thank you very much, Philip, for this beautiful presentation, this very instructive case you showed to us. Congratulations. Very nice. If I may start with one question, why did you choose leaflet therapy in this case and not annuloplasty? Would annuloplasty have been a chance, an opportunity for this patient as well?
I mean, the mechanism of TR was annular dilatation, and it was not a tremendously severe degree of tethering. So in that respect, annuloplasty would have been an option. I personally still like to do leaflet therapy, and one should not forget that with leaflet therapy, you also get some annular reduction. You sort of get an indirect annuloplasty for free, because what we actually do and what we have done here is we implant two devices to pull over the RV free wall towards the septum to reduce annular dimensions. And this is why it is very important to connect the anterior plus minus the posterior leaflet always to the septal leaflet.
Great. Georg?
Yeah, let's assume you could have done the annuloplasty in 1 hour with some iterations of the devices. Wouldn't you then have considered to do that first, because it leaves you further options open?
Yes, if that's done within 1 hour and pretty straightforward with good visualization and predictable views, then that's a different story. Absolutely.
So it's more a concern of the technical feasibility than of the technique in general.
I mean, the procedure times are certainly different at that point in time with the device and the technology we have available at the moment, and also with the imaging limitations. Yes.
How do you post-treat these patients?
So we try to leave them on the same diuretics. We observe that if the diuretic dose is reduced too early, then they might come back and they actually decompensate. So we would encourage to leave it as it, and then only during longer follow-up see whether we can reduce the diuretics. Obviously, almost all of these patients have AFib, so they have an indication for oral anticoagulation, and we see them after 1, 3, 6, and 12 months. So we keep on following them closely and try to keep the medication as stable as possible.
And you prescribe NOACs, or you stick to vitamin K antagonists? So
we normally leave what they came with. So when they were on NOACs, then that's fine. We would not put them on warfarin or anything. But when they are on warfarin and there's no problem with that, then we leave it as it.
Further questions?
How about pulmonary hypertension? Maybe another question to Leipzig. What would be your consideration there, and maybe also your cutoff, which is arbitrary anyway?
Yeah, so we focus not so much on a cutoff and threshold in terms of PA pressures. We look actually to two things, and to do that, we need to have an invasive right heart cath in all of them. We treat them when we see post-capillary hypertension, not so much when they have pre-capillary pulmonary hypertension. And the other thing we look for is whether we have a concordant diagnosis invasively and on echo, because in some patients you have high pressures invasively, but on echo you falsely underestimate PA pressures. And probably because you have very severe TR, impaired RV function, and less pressure separation between the RV and RA. All of these things are associated with inferior outcome.
And this is why we would be very careful to treat those patients with a discordant diagnosis. So these are the two things: pre and post capillary, and concordant versus discordant pulmonary hypertension. Okay, so I think we have to conclude. Thank you very much, first of all, Stefan, to you for sharing this session so perfectly, and also to all the speakers, which you all done a marvelous job, and also to the audience for listening to us. There will be some concluding remarks in just a few seconds, and we wish you a nice evening and a very successful ongoing convention. Thank you very much.
Thank you.
Okay, we had a very nice session on mitral and tricuspid regurgitation. This is a huge patient population, and we have two leading pathologies, if you will, the annular dilation on one hand, and then abnormal situations on the leaflet, I should say. And we have two devices from Edwards, the Cardioband tackling the annular dilation on one hand, and then the leaflet device, which is the PASCAL device, which has been developed for the mitral space first, and then further developed in iterations to the tricuspid space. And on the last slide, you can see what has been achieved already. We had a lot of early feasibility studies, both for the Cardioband as well as the PASCAL device in the tricuspid and also in the mitral space. And this has been followed up, or is being followed up, by post-marketing studies, again in patients with tricuspid regurgitation and mitral regurgitation. And most importantly, we also have replacement devices around the corner, which will be tested also within the early feasibility studies, and this is extremely important in pivotal trials. As you can see on the upper left corner, Edwards is engaged in various pivotal trials in the mitral as well as in the tricuspid space, and also with the EVOQUE and the M3 device in the tricuspid and in the mitral space respectively. So this is extremely exciting that we had early feasibility studies just a bit ago, a glance ago, and now we are looking already at studies with hard endpoints. So thank you very much for your attention, and thank you also to all the presenters, and I hope you're going to have a successful ongoing convention. Bye-bye.